Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you for joining me on this podcast series where we share conversations with colleagues exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this episode, we're talking with an expert neurologist on the subject of Parkinson's disease. Before starting, for Australian audiences, I just want to remind you that listening does give eligibility for your CPD, so log in and add it as an activity. You may also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, Parkinson's disease, PD, is a neurodegenerative disorder that predominantly affects the dopamine-producing, dopaminergic neurons in a specific area of the midbrain called the substantia nigra. And dopamine is the chemical messenger responsible for transmitting signals between the substantia nigra and the next relay station of the brain called the corpus striatum. And it's necessary for producing smooth, purposeful movement. So loss of dopamine results in impaired movement characteristic of this condition. And studies have shown that most people with Parkinson's have lost 60 to 80% or more of the dopamine-producing cells in the substantia nigra by the time symptoms appear. People with PD also lose nerve endings that produce the neurotransmitter norepinephrine. And this neurotransmitter is the main chemical messenger for the autonomic nervous system, responsible for controlling many of the autonomic functions of the body, such as pulse and blood pressure. So the loss of norepinephrine might explain several of the non-motor features seen in PD, including fatigue and abnormalities of blood pressure regulation. The affected brain cells of people with PD are noted to contain Lewy bodies, which are deposits of the protein alpha-synuclein. And whilst the exact mechanism governing Lewy bodies formation is not completely understood, research suggests that Lewy bodies may trigger cell death and contribute to the premature demise of neurons. Globally, Parkinson's is the most rapidly prevalent neurological disease and is currently the second most common neurodegenerative disease after Alzheimer's. It's found in 4 in 1,000 people in Australia, increasing to 1 in 100 over the age of 60. Over 200,000 Australians have Parkinson's. 1 in 5 is diagnosed before the age of 50 and 10% before the age of 40. And there are 38 new diagnoses made daily in the country. So certainly a condition we need to know a lot about. And there are 4 primary symptoms of PD, which include tremor. This shaking often begins in the hands, also sometimes in the feet and the jaw. The tremor associated with PD has a characteristic rhythmic back and forth motion. It may involve the thumb and forefinger and appears as pill rolling. It's most obvious when the hand is at rest or when a person is under stress. The tremor usually disappears during sleep or improves with a purposeful intended movement. Rigidity or a resistance to movement affects most people with PD. The muscles remain constantly tense and contracted so that the person aches or feels stiff. The rigidity becomes obvious when another person tries to move the individual's arm, which will move only in short, jerky movements, known as cogwheel rigidity. Bradykinesia. This is a slowing down of spontaneous and automatic movement that can be particularly frustrating because it may make simple tasks difficult. Activities once performed quickly and easily, such as washing or dressing, may take much longer. There's often a decrease in facial expressions, also known as the masked face. And then postural instability, impaired balance, and changes in posture can increase the risk of falls. People with PD often develop a so-called Parkinsonian gait that includes a tendency to lean forward, taking small steps as if hurrying, and this is called festination. There's reduced swinging in one or both arms. They may have trouble initiating movement. This is a hesitation that develops. They may also stop suddenly as they walk. This is called freezing. Well, PD does not affect everyone the same way, and the rate of progression and particular symptoms do differ amongst individuals. PD symptoms typically begin on one side of the body. However, eventually symptoms are bilateral. Other problems may include depression, emotional changes, dysphagia, difficulty with speech, urinary problems and constipation, prevalence of dandruff, sleeping disorders, dementia, orthostatic hypertension, pain in muscles and joints, fatigue, sexual dysfunction, and hallucinations, often caused by the drugs that are used for PD. Well, there are also several conditions that resemble PD, and these are called Parkinson's plus conditions, and they describe disorders that produce a clinical picture that is Parkinson-like with additional features. So Parkinson's plus diagnoses include multi-system atrophy, MSA, which are a set of slowly progressive disorders that affect the central and autonomic nervous systems. The protein alpha-synuclein forms harmful filament-like aggregates in the oligodendroglia, and MSA may have symptoms that resemble PD. It may also take a form that primarily produces poor coordination and slurred speech, or it may involve a combination of these symptoms. MSA with Parkinsonian symptoms is sometimes referred to as MSAP, or striatonigral degeneration. Next, Parkinson plus condition is Lewy body dementia, which is associated with the same abnormal protein deposits, Lewy bodies, found in Parkinson's disease, but appears in areas throughout the brain. Symptoms may range from primary Parkinsonian symptoms such as bradykinesia, rigidity, tremor, and shuffling walk, to symptoms like those of Alzheimer's disease, with memory loss, poor judgment, and confusion. The symptoms may fluctuate and vary dramatically. And other symptoms may include visual hallucinations, psychiatric disturbance such as delusions and depression, and problems with cognition, of course. Then there's progressive supranuclear palsy, PSP, which is a rare condition and is a progressive brain disorder caused by a gradual deterioration of cells in the brainstem. Symptoms may include problems with control of gait and balance, and people often tend to fall early in the course of PSP. They may have an inability to move the eyes and alterations of mood behaviour, including depression and apathy, as well as mild dementia unnoted. PSP is characterised by clumps of a protein called TAUR. And there's corticobasal degeneration, CBD, which results from atrophy of multiple areas of the brain, including the cerebral cortex and the basal ganglia. Initial symptoms may first appear on one side of the body, but eventually affect both sides. Symptoms include rigidity, impaired balance, and problems with coordination. Other symptoms may include dystonia that affects one side of the body, cognitive and visual spatial impairments, apraxia, which is where there's a loss of the ability to make familiar purposeful movements, hesitant and halting speech, myoclonus, and dysphagia. CBD also is characterised by deposits of the TAUR protein. Now, whilst the precise cause of Parkinson's disease is not known, and most cases are sporadic, there are several risk factors that have been identified. These include age. The average age of onset is about 70, and the incidence rises significantly with older age. But there is a small percent of patients with PD who have early onset before the age of 50, as mentioned above. Biological sex, or PD, is more prevalent in women. Heredity, and people with one or more close relatives who have PD have an increased risk of developing the disease themselves. An estimated 15 to 25% of people with PD have a known relative with the disease. Some cases of the disease can be traced to specific genetic mutations like the GBA mutation, which is the most common one, carried by up to 10% of people who live with the disease. There's also the LRRK2 gene variant, found in 1% of patients. PINK1, and this is a genetic code which codes for protein active in mitochondria. Mutations in this gene appear to increase susceptibility to cellular stress. PINK1 has been linked to early forms of PD. There's also a thought that exposure to toxins and pesticides may play a role, as may the use of illicit drugs. Well, diagnosis is based on medical history and examination, with clinical tests including MRI, CT, and blood tests excluding other conditions. There's no cure for PD, but there are plenty of treatments that we have available. And these fall into three categories. So first of all, drugs that increase the level of dopamine in the brain. So dopamine itself doesn't cross the blood-brain barrier easily. So the most common drugs for PD are dopamine precursors, substances like levodopa that cross the blood-brain barrier and are then changed into dopamine. Other drugs mimic dopamine or prevent or slow its breakdown. For example, levodopa is combined with carbidopa, which prevents the conversion of levodopa into dopamine peripherally, but not centrally in the brain. COMT inhibitors, which stand for catechol O methyltransferase, is another enzyme that breaks down dopamine, and the drugs entacapone, opicapone, tolcapone prolong the effects of levodopa by preventing the breakdown of dopamine. The second class are drugs that affect other neurotransmitters in the body to ease some of the symptoms of the disease. For example, anticholinergic drugs, which interfere with production or uptake of the neurotransmitter and include acetylcholine, trihexyphenidyl, benztropine, and ethopropazine. This can be effective in reducing tremors. And then there's amantadine, which is an antiviral drug. It has an unknown mechanism of action but can help reduce symptoms of PD and levodopa-induced dyskinesia. It can be prescribed alone or in the early stages of the disease and can be used with an anticholinergic drug or levodopa. And finally, there are medications that help control the non-motor symptoms of the disease or the symptoms that don't affect movement. For example, antidepressants treating the depressive-associated side effects of the disease. And then there's surgery. And before the discovery of levodopa, surgery was an option for treating PD. Palidotomy and thalamotomy have now given way to deep brain stimulation, which is generally appropriate for people with levodopa-responsive PD who have developed dyskinesias or other disabling off symptoms despite drug therapy. And deep brain stimulation uses an electrode surgically implanted into the subthalamic nucleus or the globus pallidus. The pulse generator stimulates the brain in a way that helps to block signals that cause many of the motor symptoms of PD. Well, in this episode, we have the privilege of exploring this subject further with Associate Professor Ernie Butler. a consultant neurologist and founding member of Frankston Neurology Group. Ernie has major clinical expertise in the management of multiple sclerosis, myasthenia gravis, and Parkinson's disease. He has appointments as the head of neurology at Peninsula Health, as a senior neurologist at Monash Health, and as the head of the Monash MS Clinic. We've had the honour of working with Ernie previously in episode 88, exploring multiple sclerosis, and episode 89, discussing myasthenia gravis and Guillain-Barré syndrome. I could certainly refer you back to those episodes for your interest. Please welcome him back to the podcast. Dr. Ernie Butler, thank you for joining me on Everyday Medicine again, and for being so patient with my overtures to getting you back on, Ernie, because I really enjoyed our first discussions about MS and Guillain-Barré. We're going to talk about a neurodegenerative disorder, Parkinson's disease, today, and this is one of your special interests as well. And Parkinson's is said to be the second most common neurodegenerative disorder after dementia, and some estimates are that up to 200,000 Australians have this condition, and there's something like 34 to 35 new cases diagnosed every day. So it's a very big problem for Australian GPs. I'd like to pick your brains about this condition, improve my understanding, share that information with other people, maybe you're listening to the podcast. Can you tell us a little bit about the prevalence, Ernie, and then we can talk a bit about etiology and how we should recognise it, move into phases of treatment and so forth?
Look, I guess I'm going to be a little bit anecdotal and say that I see a number of new cases of Parkinson's per year. It's a very common neurological condition that I see in my practice, and it's becoming increasingly common. And I think the estimate was that the incidence of Parkinson's has doubled in the world in the past 25 years. Mm-hmm. So we're going to see more of this insidious neurodegenerative disorder, and it's going to, continue to pose problems for the health system. It's an interesting condition to treat.
Do we know why it's increasing, Ernie? Is that because it's more, you do see occasionally young people, even from the age of 30 or so, but is it because we're, as a population, living longer, so we're seeing these degenerative disorders with high prevalence, or is there some other factor at play?
Look, I don't think we really know why. I mean, the etiology of this condition is a mix between genetics and the environment, and perhaps there are more environmental influences coming to the fore. Unfortunately, we're seeing more of it all the time.
So, it's all about. It seems to me the clinical condition is all about dopamine depletion, in the substantia nigra and elsewhere.
That's been the hallmark of, pathologically diagnosing Parkinson's for many years. That we used to think it started in the substantia nigra, depletion of dopaminergic neurons in the substantia nigra pars compacta. But in fact, Parkinson's is more than just a single neurotransmitter disorder. There are a number of neurotransmitters that are important in the genesis of why patients get particular problems in Parkinson's. But the most prominent feature is certainly depletion of dopamine throughout both the peripheral nervous system, including the autonomic nervous system, as well as the central nervous system. There are various theories about how Parkinson's starts, and I think we generally think these days that there's this condition is an alpha-synucleinopathy, and we see that there's Lewy body deposition, which is intracytoplasmic inclusions that are seen both in the olfactory nervous system to start off with, the olfactory nerves, and in the enteric nervous system and in the lower part of the medulla. And then it spreads from there. It spreads up in the brainstem to the substantia nigra, and eventually over time it inevitably spreads into the cerebral hemispheres and affects the cerebral cortex. And that's why people get cognitive decline in this condition, and eventually many patients develop dementia.
That's the frontotemporal dementia. Can you have that frontotemporal dementia as a separate entity without the other effects that we might see in Parkinson's?
So I'm sorry, that's Lewy body dementia.
Yes. Can we get that? Well, we can see that without the other.
You can get Lewy body dementia as a diagnosis, and patients may or may not have Parkinsonism features at the onset. but usually within the first year or so of them being diagnosed with Lewy body dementia, they do develop Parkinsonian features. So it's, and those patients have, cortical Lewy bodies from the outset.
Right.
They haven't developed the motor features that we typically see with Parkinsonian dementia, which occur years before.
Ernie, if you have Parkinson's disease, is it possible to do a genetic test to see if you have a hereditary form of that?
Look, it is possible. It's not commonly done in clinical practice, but it's estimated that 5 to 10% of cases of patients with Parkinson's have a genetic etiology, and there are a number of genes that have been identified in this space in the past few years. I guess the commonest ones would be the Parkin gene, the LARC gene, the pink gene. Yes. But there's a whole host of other genes that have been identified, which account for small proportions of patients who have genetic forms of Parkinson's. And in practice, I always take a family history when I see a patient for the first time. Most patients have sporadic Parkinsonism, but occasionally you'll see, my father had Parkinson's, my mother, my uncle, or whatever, and those patients clearly are likely to have a genetic form of Parkinsonism. But in practice, we don't usually send them off for genetic testing. But in the future, this may become more common and certainly more relevant for patients, particularly if we have disease-modifying therapy for this condition.
More sort of personalised medicine. Yeah. So someone said to you, well, I've got Parkinson's, Dr. Butler, perhaps I'll rephrase it. My mother has Parkinson's and my father has Parkinson's. Can you give a probability of them developing Parkinson's, or is that just too hard a question to answer?
Look, it's too difficult at the moment. I say fairly confidently, it's unlikely if one parent has it that you're going to get it. It's unlikely. But if you want specific genetic, pre-symptomatic genetic testing, then they need to go and see a genetic specialist about that.
I suspect if you did see a genetic specialist and you're able to do that, through a private payment, if you had that gene, it possibly wouldn't necessarily mean you're going to get Parkinson's disease either.
That's true. You don't always get complete penetrance if you have these genes, and that's why the environmental influences in Parkinson's are also important. Yeah.
Do we know what they are, Ernie? What sort of environmental?
Well, most of this information comes from epidemiological studies, and it's said to be more common in people, for instance, in boxers, I guess, like Muhammad Ali, people that have head injuries, people who live in the country, people who live on, farmers, people who are exposed to pesticides, organophosphates, and the like. Those sort of factors increase your risk, and there are factors that reduce the risks, like smoking, for some reason, reduces the risk of developing Parkinson's.
That's interesting. It's a bit like ulcerative colitis has the same, reverse association
with smoking.
Yes, Crohn's disease more likely and hard to manage, but ulcerative colitis seems to be somewhat protective, and often seem to have flares of inflammatory bowel disease, in fact, or first presentations when people have just suddenly stopped smoking, which of course is what we're all recommending. But it is an interesting association. How would we recognise it, Ernie? What would be the early signs of this in a clinical practice?
Well, I'm going to start by talking about prodromal Parkinson's, because occasionally I'll see a patient with prodromal Parkinson's, and I'll say to them, you have an alpha-synucleinopathy, and it's likely you're going to develop either Parkinson's, Lewy body dementia, or multiple system atrophy in the future. And those patients, generally the patients who are referred by sleep specialists with, REM behavioural disorder. It's a behavioural disorder that occurs during the REM phase of sleep. It can be seen sometimes 5 to 10 years before patients develop motor features of Parkinson's. And the spouses of the patient give the story that, during the night, they sometimes they sometimes live out their nightmares or dreams. They start kicking or punching, screaming, yelling, and sometimes get injured. Sometimes these patients fall out of bed and injure themselves because they sort of dive out of bed as part of their dream or nightmare. And these sort of things can happen, as I said, for years before. Patients with prodromal Parkinson's also are more likely to develop anxiety and depression for the first time, to develop constipation because of the autonomic nervous system being affected by Parkinson's. and to develop, reduced ability to smell, or what we call hyposmia. And so if you can identify a patient at that stage, and if we had a disease-modifying therapy for Parkinson's, this would be the time to intervene.
Yes.
But of course, we usually don't diagnose Parkinson's until they develop the motor features. And the motor features of Parkinson's are, the ones we were taught as medical students, the cogwheel rigidity, the bradykinesia, and the rest tremor. And the fourth thing is impaired postural reflexes, but that's not usually a feature until someone's had Parkinson's for a few years.
Right.
And just going through those, the rest tremor is typically, a 3 to 5 hertz pill rolling tremor.
Yes.
It was first identified by James Parkinson's over 200 years ago. And you see it when patients walk up and down the corridor, they don't swing their arm, they have a rest tremor in the affected side. It's usually an asymmetrical disorder at onset. The rigidity is usually cogwheel rigidity, and the bradykinesia is usually tested by doing rapid repetitive movements in the upper limbs. Occasionally it presents in one leg, but most commonly it affects one hand to start off with. And it's usually for a neurologist a spot diagnosis when they walk into your room.
If you don't have any other tests, these are all clinical signs, clinical features that you put together. There's no test that you can actually do otherwise. We're so reliant on them in other forms of medicine. I'll do this blood test or that X-ray or whatever, and we'll get the diagnosis. We don't have that for Parkinson's. Is that correct?
We don't have a biomarker, although, there'll probably be a biomarker coming in the future in terms of doing a skin biopsy, for instance, of alpha-synuclein. But if occasionally I'm unsure, or if I see someone with what I think is likely to be a prodromal synucleinopathy, then I will sometimes send people off for a PET scan, and you can actually measure dopamine in the brain on a PET scan, and that confirms that someone has dopamine depletion. But usually clinical diagnosis is all that I need to make a firm diagnosis. I can be fairly confident.
Right, so that dopamine scan you're referring to, dopamine PET scan, you wouldn't order that necessarily unless you had some uncertainty maybe.
That's right. If there was some uncertainty, I might order it, or someone has very mild features. Yes. I saw someone last year who came to see me for a completely different reason. And when I did a neurological examination, I noticed that she had very mild Parkinsonism on one side of her body. I wasn't completely sure, and she's a fairly high-functioning individual, so I sent her off for one of these scans and came back as being positive. So it's not a test that we order very much in Australia unless there's a good reason to do so.
Right. Can you just explain that term alpha-synuclein? Could you explain that to me?
So that's a protein that we all have in our body, but in Parkinson's disease, it's present in abnormal amounts in the nervous system. It's deposited inside the neurons, and it's a significant component of Lewy bodies,
yes,
which are the pathological hallmark of idiopathic Parkinson's disease.
Thank you. So, Ernie, we're going to talk about more about treatment and so forth, but Parkinson's plus conditions, I don't know if I should throw that in here as a question mark. Think about multisystem atrophy and corticobulbar diseases and so these various conditions that are called Parkinson's plus conditions. Are they easy to differentiate from Parkinson's early on or not really? And would that dopamine PET scan that you mentioned help us or not so?
You'll still see dopamine depletion in those conditions.
Right.
But for the Parkinson's plus syndromes, yes, sometimes it's a very good question because sometimes we can't tell, or I can't tell, and there is a misdiagnosis rate in Parkinson's disease, perhaps as high as 10 to 20% of patients who are initially labelled as having Parkinson's disease actually turn out to have one of these Parkinson's plus syndromes. And the most common types we see are progressive supranuclear palsy, or PSP.
Yes.
And the other one is MSA, multiple system atrophy. Corticobasal degeneration, in my experience, is actually fairly rare.
Right.
Yeah.
Can I just ask you at this point how you might differentiate those three conditions, or would you like to talk about that toward the end?
So no, we can certainly talk about it now. The idiopathic Parkinson's disease, usually unilateral onset. Those cardinal features that I talked about before, and the other thing is that they're dopamine responsive. Usually, they're very they have a very good response to levodopa.
Right. Okay.
When you introduce it as their initial treatment. Now, someone with PSP or MSA is less likely to be dopamine responsive. Occasionally, patients with these Parkinson's plus syndromes will be initially dopamine responsive and then not become dopamine responsive. But there are red flags for people with Parkinsonism where it's not going to be Parkinson's disease. And for instance, someone with PSP, progressive supranuclear palsy, may or may not have eye signs, which you won't see in Parkinson's disease. That's how it gets its name.
Right.
So supranuclear palsy is referring to limitation in down gaze and sometimes up gaze and horizontal gaze as well, and slowed saccades of eye movements. And someone with PSP is much more likely to have an abnormal gait at the onset, which rapidly becomes more unstable, and they have a marked tendency to fall. Okay. And you don't tend to see that in Parkinson's disease for a few years. And someone with MSA, the characteristics of MSA or multiple system atrophy, as the name implies, multiple parts of the nervous system are affected, and they characteristically have to meet criteria for MSA, which includes involvement of the autonomic nervous system, as well as Parkinsonism, sometimes cerebellar disorder or MSAC, and sometimes these patients will also have pyramidal signs, and they will also go on to have other features as time goes on. So that's usually a fairly characteristic disorder. And when it affects their autonomic nervous system, most people with MSA develop early autonomic features or sometimes before they develop Parkinsonism. And what I'm referring to is quite severe orthostatic hypotension or what's called neurogenic orthostatic hypotension. So marked fluctuation in blood pressure, particularly towards the lower level. And they often have urinary difficulties as well, a neurogenic bladder. So they're often early features of that condition. So that helps it distinguish from Parkinson's patients who can develop some of these features that I've just spoken about, but usually at much later stages of the condition.
Yes, I see. Well, thank you for clarifying that, because I know a few patients who've presented with those conditions, and they do seem very difficult to manage. And can I also just clarify in terms of overall prognosis, lifespan, Parkinson's versus the Parkinson's plus conditions? Can you tell us a little bit about that, what we could expect to tell a patient in terms of their lifespan?
Yeah, well, for the Parkinson's plus syndromes, MSA and PSP, the lifespan's usually of the order of 5 to 10 years from diagnosis.
Yes.
Yeah. So it certainly shortens their life.
Yeah.
It's much more rapidly progressive and disabling condition than Parkinson's is for the first few years.
Yeah.
With Parkinson's disease, from diagnosis, they will have a shortened lifespan, but certainly not by as much as what you see with the Parkinson's plus syndromes.
Yes.
And most of my patients with Parkinson's, I guess it depends on the age they are at diagnosis as to what their lifespan is going to be, because the older you are, the more likely you are to develop Parkinson's. Age is an important risk factor for that condition. But most of my patients generally live for at least 10 to 15 years or sometimes even longer. But if they're elderly at the time of the diagnosis, then of course they're not going to survive for as long.
Yes, they're going to have complications.
Yeah.
What's your approach to medication or treatment, I should say, not just medication, but treatment? Take us through that.
So for Parkinson's disease, the gold standard of treatments, which was initially described in the 1960s, remains a gold standard. That's levodopa. And there are various levodopa preparations available, but most neurologists would prescribe levodopa at the time of diagnosis, because by that time patients are already complaining of clinical problems. And most patients that I see describe problems with upper limb function. They've already got trouble brushing their teeth or doing simple things like feeding themselves or dressing themselves. Doing up buttons is a particular problem with Parkinson's disease.
Yeah.
Drying themselves after a shower is slower. Everything's slower. The bradykinesia is the big problem for most people. Some people with tremor, they're quite shy to go out in public because they don't want people to look at them or to comment, or they don't want their friends to see, or it's just troublesome for them.
Yeah.
So they want to abolish the tremor. So levodopa usually achieves all of that as monotherapy. And there have been, clinical trials to show that levodopa is not toxic to neurons, so it's safe to take. So really, patients derive benefit as soon as they develop, concerning or worrying symptoms from taking levodopa. Usually it's given 3 or 4 times a day. Sometimes it's given at bedtime if patients are describing trouble turning over in sleep or are having symptoms first thing when they get up in the morning.
And it has to be combined with a decarboxylase inhibitor in all situations, like carbidopa or benzodiazepine. Okay.
Yeah, and the reason for that is to just minimise the amount of nausea that the patient would get if they were taking levodopa on its own, because this allows more bioavailability of levodopa when it crosses the blood-brain barrier into the brain.
Right. What about the other drugs that we have available? Because there are lots of other dopamine agonists and so forth that are available.
I mean, certainly the longer someone has Parkinson's, the more likely they are to be on combination therapy for Parkinson's. So we have, direct dopamine agonists for the treatment of Parkinson's disease. We have drugs that help slow down the enzymatic metabolism of dopamine in the brain. We have drugs that allow dopamine to hang around for longer at synapses. But dopamine agonists I use less of than I did in the past. I'm very selective about who I give a dopamine agonist to, because dopamine agonists come with a significant side effect profile, and that is a significant proportion of patients develop an impulse control disorder on these drugs. What I'm referring to is excessive gambling behavior. I've actually had a couple of patients go bankrupt as a result of being on dopamine agonists, and I was unaware that they were gambling away their lives. It can cause excessive shopping behavior, excessive eating behavior. Hypersexuality can be a problem. So if these things occur, I usually reduce the dose or just withdraw them completely. Although another special thing about dopamine agonists is that you have to withdraw them slowly. If someone's having side effects, there's no point just suddenly taking them off it. They can get a dopamine withdrawal syndrome where they feel very unwell, anxious, sweating, sometimes almost like a neuroleptic malignant-like syndrome can occur if you're on a reasonable dose and you suddenly withdraw it.
Right. That's an important point. So would you ever use those drugs by themselves, just granted the difficulties and issues you've just discussed with them? Are they ever used by themselves, or is it always, we'll complement the levodopa?
I once upon a time, I used to use it in younger patients as a single agent, because you can give dopamine agonists as either as a patch or as a tablet, and it's taken once a day, so it's easy to remember, better compliance, but they're never as good. And clinical studies have shown this. The motor benefit from dopamine agonists is not as good as levodopa. You can't achieve the same level of control of Parkinsonian symptoms and signs with the dopamine agonists. And as I said, I've just become wary over the years because of my experience of patients developing the impulse control disorder. They just have abnormal impulses.
What else do you turn to medication-wise, Ernie? What's your next choice? After consideration.
After levodopa, it depends on the clinical indication and what the problems they're having with the motor control of their Parkinson's. Okay. So if someone, and the biggest problem with Parkinson's motor management is probably the fluctuations we see in motor control. So after first 5 years of Parkinson's is the so-called honeymoon period of treating. You just give patients usually 3 times a day levodopa as monotherapy. They do very well. They come and see you, every 6 months, and they're very
reasonably stable on the therapy.
Very happy. But then after about 5 years or so, the next 5 to 10 years, patients develop what we call motor fluctuations, or what used to be called on-off phenomena. So in other words, because of the pulsatile nature of administration of levodopa, and therefore the pulsatile nature of dopamine inside their brain, they can have periods of time where, with higher dopamine levels, they have what are described as dyskinetic movements, which are just choreoathetoid involuntary movements, and they're usually peak dose dyskinesias, or they can have off phenomena where they're just more tremulous, slow, have difficulty moving, so-called off-phase phenomena, or they can have what we describe as wearing off phenomena, where between one dose and the next, for instance, between your breakfast dose of levodopa and your lunchtime dose of levodopa, before you get to lunchtime, you're starting to slow down, tremors coming back, you're not doing as well. and we just call that a wearing off phenomena. So it depends on exactly what a patient describes to you at the consultation as to what you might do next. But in terms of the dyskinesias, you can dampen dyskinesias by using a medication called amantadine. It's pretty easy to add. It's usually just taken morning and lunchtime. In terms of
that's an antiviral therapy. That am I right in saying the way it works is not perhaps completely understood, or it was.
Look, it was initially developed, I think, back in the 60s or 70s as as you say, an antiviral medication to try and prevent people getting influenza A.
Yes.
And it was serendipitously shown in an elderly group of patients to have a dopaminergic action.
Yeah.
So it's helpful in the management of Parkinson's. We've been using it ever since. And these days we only use it to try and dampen dyskinetic movements, those involuntary chorioathetoid movements I referred to.
Yes.
Look, another way to treat people with on-off phenomena or, the motor fluctuations is to, instead of giving medication just 3 times a day, is to give it every 3 or 4 hours, 4 times a day.
Yes.
And just to give it in smaller doses so you have less of the peaks and troughs of levodopa concentrations in the bloodstream and getting through to the brain. Another way of dealing with it would be to perhaps introduce a dopamine agonist and reduce the levodopa dosage. Another way to deal with the wearing off effects of levodopa is to give a COMT inhibitor, catechol methyltransferase inhibitor.
Yes.
There's a new one available on the market this year in Australia called opicapone, which is just given once a day. So there are various Parkinson's preparations or medications available to help patients deal with these sort of motor fluctuations.
Are we working on a subcutaneous delivery of, like a continuous delivery of a drug like levodopa? Is that sort of perhaps where the future might be, so you don't get these fluctuations you're referring to?
Look, there is one actually, it's interesting you ask it, because there is one that's being trialled at the moment.
Right.
And that's certainly, there's a new formulation of levodopa that can be given subcutaneous, so it can be delivered 24 hours a day.
Yeah.
But that's in the pipeline.
Right.
There is for people with quite advanced Parkinson's who have trouble with swallowing or have a lot of motor fluctuations, we can give it via, a PEG tube.
Yes.
And that's a gel form of levodopa called duodopa. But in my experience, it's rarely employed for the majority of Parkinson's patients.
Ernie, monoamine oxidase inhibitors, lots of side effects, but are they used or not so much now in clinical management of Parkinson's?
They are used in Parkinson's. They're mostly used to increase on time. In other words, when a patient can move normally throughout a day, and clinical trials have shown that they do increase on time. They're actually pretty safe, the ones we use in Parkinson's.
Right.
So we use racegiline, and there are other agents as well. Sulfonamide's another one that comes to mind, and it can just be given once a day, and they can be given safely without the, the potential side effects that we heard about Mayo inhibitors being used in psychiatry back in the day.
Well, when would you use that rather than a COMT medication? They're sort of working in a similar kind of way to prevent breakdown of dopamine. But
if someone's not going too badly on levodopa, but they have a bit of off time throughout the day unpredictably, I would probably add in a MAO-B inhibitor.
Right.
A COMT inhibitor is more likely to be used if you want to prolong the action of levodopa throughout the day.
Right.
So, it's...
Lots of nuances. These are the nuances of being a neurologist.
There are. It's just, I guess, a matter of experience about knowing what's the best agent to use in that situation.
You mentioned at the start that it's not just dopamine, although dopamine is the main neurotransmitter we sort of recognise, and you have to have 70% or more depletion, I understand, before you generally develop these symptoms, and now we're replenishing it in these ways. What about the other neurotransmitters? Do we have ways of tackling those?
Not really. I mean, I guess I was referring more to the theory about how Parkinson's signs develop.
Yes.
And, for instance, how people become bradykinetic because of the network hypothesis about how Parkinson's works in the basal ganglia through to the thalamus and cortex.
Yes. Okay.
And there are different pathways with different neurotransmitters that are involved. And there are also different brainstem areas that are involved rather than just substantia nigra the locus ceruleus and other areas where other neurotransmitters are important.
Yes, it's more complicated than just the substantia nigra. Other drugs that we ought to be very careful of in clinical practice, that if someone's got Parkinson's disease, we should be aware of this in clinical practice, not to give these drugs. Like some things, like some of the motility drugs we use in gastroenterology can exacerbate disease. Can you make a little comment about that, drugs that we should perhaps be avoiding?
We certainly should be. I mean, there's certainly drug-induced Parkinson's would be a common cause of Parkinsonism, not idiopathic Parkinson's disease. And that's why the drugs that cause it are usually the antipsychotics. Any of the antipsychotics, particularly the older generation antipsychotics, are more likely to cause an extrapyramidal side effect such as Parkinsonism. And I saw a case of a patient this week with that. And you're right, drugs like Stemetil or Maxilon, I always tell my patients to avoid or never take them. And if I have to give them something for nausea, I usually give them domperidone, which will not deplete dopamine in the central nervous system.
Right, whereas Maxilon and Stemetil, prochlorperazine.
I occasionally see people who have been on Stemetil for years, 3 times a day to treat dizziness.
Yes.
And they'll come along and they've got Parkinsonism.
Yes.
And I'll say, stop this drug, come back and see me in 3 months.
Yes.
And usually they're better by the next time you see them.
Yes. It's important these things keep getting reinforced, isn't it? So, metoclopramide and prochlorperazine are ones we have to be careful of and not use long term. That often gets forgotten, I think, in clinical practice.
That's right.
Do you have other non-pharmacological treatments that have great merit? I guess, we think of physiotherapy, immobilization, maintaining strength and so forth. It's going to be good for posture. Are there any other things that we should be thinking of in clinical practice, referring a patient off for other ancillary services?
Look, haloid health is certainly very important in the management of someone with more advanced Parkinson's. First few years, patients don't need it. But and in fact, I should have said earlier, one of the protective things that you can do to try and reduce your risk of getting Parkinson's in the future is high intensity aerobic exercise. And I always tell my patients that there are only 2 things that I know that work in Parkinson's so far. One is the drugs you need to take, and the other is regular exercise. I always recommend my patients get out there and exercise on a regular basis. It helps not just with their Parkinson's, but also with their mental health. It depends on what exercise they're comfortable with as to what they do. Most patients in that age group will go out there and walk on a regular basis. Some of them do an amazing amount. If patients are swimmers, go out there and swim. Got some patients who go ocean swimming, for instance, like those icebergers you hear of. I've got some patients, even at a more advanced age, who I have one guy who'd like to go out on an electric scooter, another guy who would like to go out surfing, and the guy who took up swimming for the first time. So as long as they're out there being active and doing exercise, that also helps with the management of Parkinson's. There was actually a trial showing that people with Parkinson's can cycle sometimes better than they can walk. So cycling can also help, except for perhaps if they have gait freezing or balance troubles. Just be careful at the traffic lights.
It's almost like they're distracted. There's a lot of distraction occurring when they're riding the bike, perhaps, I wonder.
It's something about the circular nature of using your legs on a regular nature for some reason, or even some people, there's studies showing that ballroom dancing is helpful for Parkinson's patients.
Does the tremor of Parkinson's continue during sleep, Ernie?
No, the tremor of Parkinson's should disappear during sleep.
It turns on because there's no stimuli coming into that part of the midbrain.
That's right. It should switch off during sleep. We're not entirely sure what causes the tremor of Parkinson's, but probably got a lot to do with network circuits between the cerebellum, the thalamus, and the motor cortex and the basal ganglia. But no, when you sleep, it switches off. When you do movements, it tends to be, a lower amplitude, and a lot of patients with Parkinson's are not that fussed by their tremor because they can still do everyday things. As I said before, sometimes they're embarrassed by it, so you have to get on and treat it.
You mentioned a little about deep brain stimulation. Is that something that you consider for patients? And if so, which patients would you select and refer
Yeah, I definitely consider in a patient, I have to be a well-selected patient. I mean, it's been around for a long time. It's very effective treatment. And my patient of choice would usually be a younger patient with Parkinson's who has intact cognition and who has marked motor fluctuations despite maximal medical therapy. In other words, they've got a lot of dyskinetic movements, a lot of on-off phenomena, and you can't control it with medical therapy, and it's interfering so much with their life that they need to consider surgical therapy. And look, deep brain stimulation surgery is done in most big public hospitals or tertiary centres in Australia now, with carefully selected patients. The hospital stay is very short. The target for this surgery is usually the subthalamic nucleus. So usually an electrode will be put into both subthalamic nuclei, usually with very low morbidity, and it's very effective therapy. And patients can usually stop a lot of their Parkinson's medication. Occasionally patients stop all Parkinson's medication, but I guess the majority would stay just on lower dose levodopa therapy, and therefore won't have the side effect profile of being on high dose combination therapy for Parkinson's.
Can you explain how that works? How that electrical stimulation is thought to work in this instance?
Yeah, so the patient's electrode's attached to a battery, and it's situated just under their left clavicle, usually, just pretty much like a pacemaker, delivers constant electrical stimulation at high frequency through the electrode tips to the subthalamic nucleus. I think it's thought to cause, because it's been given at high frequency, it switches off the subthalamic nucleus neuronal activity, which is important in one of the network pathways of genesis of why people have Parkinsonian motor symptoms, and therefore switches off the signs that you see with Parkinson's.
It's fascinating. It's an interesting concept that someone's come up with there. But Ernie, this has been a tremendous discussion of Parkinson's, and I really appreciate your expertise in taking us through this. Is there one thing you could maybe convey, like, to someone who has Parkinson's disease, like an optimistic sort of? Is there a little optimistic comment that you could convey in terms of someone who's just been brought forward with that diagnosis?
Yeah, look, I'd reckon. I mean, Parkinson's is, although it's a common neurodegenerative disorder, is a very treatable neurodegenerative disorder. We have many treatments that will help resolve many of the motor symptoms of Parkinson's disease. We also have treatment for the non-motor symptoms of Parkinson's disease, which we haven't discussed, but which will make a person's life much easier for many years. And someone with a diagnosis of Parkinson's, at diagnosis, can be reassured that they will have many more good years where they can engage in normal activities and be socially engaged, get out and do stuff and enjoy life.
Ernie, thank you very much. Really do appreciate your expertise and look forward to seeing you again soon. Thank you.
Thank you, Dr. Luke.
I would like to thank you for joining me with Associate Professor Ernie Butler on this mammoth subject and extremely important subject of Parkinson's disease. I hope you've gained some insights and that this podcast has improved your clinical awareness of this very important condition. Next week, we'll have another interesting guest to advance our podcast series. We will be covering a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients, but as general information only, and reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed and can be emailed to manager@geohealth.com.au.